This is the University of Kentucky Department of Anesthesiology YouTube channel, and today we're covering Anesthesiology Keywords, Orthopedics and Anesthesia. Looking at the keywords over the last more than a decade, they're represented here in the categories of embolism, tourniquet, and some other complications. Regional will be covered in a different videocast. 2018 are represented in green. 2019 ABA ITE Keywords are represented in purple. So under embolization, you can see air embolization. There's been questions developed around this topic multiple times. Orthopedic surgery, risk for air embolism, fat embolism, some of the signs, hip fracture and fat embolism, tourniquets, both inflation and deflation, and some of the metabolic effects of inflating a tourniquet, tourniquet pain, and then postoperative complications like blindness, especially associated with spine surgery, breakdown of muscle, rhabdomyolysis, and peripheral compartment syndromes, some complications of rheumatoid arthritis, including Atlantoaxial instability, and then methyl methacrylate or bone cement and some of the problems associated with it. So let's start right in on air embolism as our first keyword. Anytime a vein is open above the level of the heart, air can be entrained. Examples in orthopedics include beach chair position, prone spine surgery where the spine is above the level of the heart and a vein is opened, air could be entrained, cervical spine surgery in the sitting position, and even hip surgery in the lateral position. Let's say the right hip is up and the heart is down, and while they're working on the right hip, a vein is open, potentially air could be entrained. When you have air that is entrained, the bubbles go to the right side and can occlude the pulmonary vasculature. A sudden decrease in end-tidal CO2 because of the increased dead space, blood coming back is blocked, but ventilation continues, therefore dead space. So the end-tidal CO2, which was 35, suddenly goes down to 15 or 18, for example. The right heart doesn't like it. Blood pressure can drop, cardiac output can drop. The right side can dilate because of it trying to eject against that blood that is blocked by the air, and the pulmonary artery pressure can actually rise. So if this is occurring, a sudden drop in end-tidal CO2 in these at-risk procedures, inform the surgeon, flood the surgical field with saline, support the heart, often with low doses of epinephrine, and lower the site of the open vein, if possible, to below the level of the heart to stop the entrainment of air. The picture at the top is from Atlas of Clinical Anesthesia in a chapter I wrote, and it talks about air embolization. In this case, it's showing some of the monitors, and it doesn't take much air to be detected on TEE, which is very sensitive for detection. We don't use Doppler very much anymore, but a Doppler on the chest wall, you can hear the changes as air goes into the heart. It takes a lot more air to start causing problems like elevations in pulmonary artery pressure, drop in end-tidal CO2, drop in cardiac output, and rise in CVP, and eventually severe hypotension, EKG changes, and the mill wheel murmur that is characteristic but rarely heard. Fat embolism is the next key word. Often follows after a long bone fracture, 12 to 48 hours thereafter. So a motor vehicle accident, young person sitting in the holding area, has a saturation less than 90%. And you go, what happened? Did they have thoracic injury also? Do they have a pneumothorax? And in this case, if they've had a long bone fracture, you should put fat embolism into your differential diagnosis. Fat embolism can occur during reaming of a femur, during hip surgery. And in the case of a long bone fracture, some of the criteria for fat embolization syndrome include these axillary petechiae, and those are shown in the picture on the far right. Blockage of capillaries with these fat globules. The lung can be involved with hypoxemia ensuing, PaO2 less than 60 on an FiO2 of less than 40, or greater than 40, that is. CNS depression, the brain can actually get some of those fat emboli. Those are the major criteria: axillary petechiae, hypoxemia, and CNS depression, while minor criteria include some non-specific things like tachycardia and fever, decreased platelets. And if you're really good at looking in the back of the eye, you might see some fat emboli in the capillaries there, and you might be able to get some fat in the urine, although we rarely would test for that. So it's the major criteria that we're usually looking for. Once we diagnose it, the treatment is to stabilize that fracture and stop those fat emboli from being released into the bloodstream. Respiratory support may be needed with intubation and PEEP. Steroids are controversial, and really there is no pharmacologic treatment that's effective, but simple ventilatory support and with resolution hopefully quickly. Venous thromboembolism is the next topic. It's a major cause of death after total joint replacement or trauma to the lower extremities. Therefore, the reason why orthopedic surgeons are so adamant about different types of prophylaxis and making sure a patient has had anticoagulation prophylaxis, because about 40 to 80% will have venous thrombosis, and 1 to 28% will actually have clinical or laboratory evidence of pulmonary embolization if they do not have prophylaxis and undergo orthopedic procedures or have fractures. The highest rate of embolization occurs during hip fracture and surgery for hip fracture, and it can be fatal in 0.1 to 8% of cases. So very important to prophylax against venous thromboembolism in orthopedic cases. Signs and symptoms of venous thromboembolism: if they're awake, they may be short of breath, breathing fast, have pleuritic chest pain, their saturation drops. Intraoperatively, hypotension, hypoxemia, and bronchospasm, along with decreased end-tidal CO2, are some of the things that can be seen. That decreased end-tidal CO2 from like 35 or 40 suddenly down into the teens, and with a large PaCO2 to end-tidal CO2 gradient is frequent. That is, you draw a blood gas and the CO2 might be 60, while the end-tidal CO2 is like 20. Other things, if you draw blood, you may be able to pick up the D-dimer that's present from fibrinolysis that's going on. If you put an echo down, you might see a dilated right ventricle, like the picture on the far right, a tricuspid regurgitation from dilation of the right ventricle and pulling apart the tricuspid annulus, and a low volume in the left ventricle. That would be classic TEE echocardiographic picture of a venous thromboembolism, a pulmonary embolism, with the right heart struggling to eject blood into that blocked pulmonary vasculature. Echo is one of the things to diagnose pulmonary embolization. D-dimer is a blood test to detect it, and CT and angio are often used to visualize the thrombus. The next keyword is tourniquet management. Tourniquets are placed on extremities, lower extremity and upper extremity, to reduce blood loss during procedures on those extremities, and also to make it easier to see the anatomic structures that you're operating on. The thigh cuff usually is about 100 millimeters of mercury above systolic blood pressure. The arm cuff about 50 millimeters of mercury above systolic pressure, to make sure there's no blood that is in the surgical field while they're operating. So, prolonged tourniquet inflation, by definition greater than 2 hours, is associated with neurologic and or muscle injury. So we don't want to leave a tourniquet up for an extended period of time. The muscle can die, rhabdomyolysis can occur, the nerves cannot get enough oxygen, you can have permanent neurologic injury. Absolute contraindications to a tourniquet being inflated on an extremity. Sickle cell is one of those, because if you inflate a tourniquet and the blood cells in that extremity, the red blood cells, don't have oxygen around them, they can sickle, and so you can cause a sickle cell crisis. If someone has severe peripheral vascular disease, they barely have enough blood going in that extremity, and you blow up the cuff, you can cause problems with perfusion of that extremity, and ischemia and permanent injury. If someone has ongoing ischemia to an operative limb, or if they have a bad peripheral neuropathy, that might be a contraindication. A dialysis graft, probably wouldn't want to put a tourniquet around a functioning dialysis graft and potentially clot it off. Or if someone has an infection in the operative limb. Those last ones are relative contraindications. Tourniquet pain, when that tourniquet is inflated to those high pressures, there's a gradual increase in blood pressure that often occurs, and a dull, burning, deep and poorly localized pain that if the patient is under regional anesthesia, they may complain of. It often occurs within 30 to 60 minutes after the tourniquet is inflated in a large number of people during limb surgery under regional anesthesia. Well, what do? Your regional is working great, but they're having tourniquet pain. You can deepen anesthesia like intravenous fentanyl or intravenous ketamine. You can potentially use a double cuff, which from the very beginning, if you have one cuff inflated and the other one down, you can inflate the other cuff and let the other one down and potentially reduce tourniquet pain. Intercostal brachial and muscocutaneous nerve blocks for the arm may be used, especially the intercostal brachial that comes over from the chest wall, and a ring of local anesthesia along the medial upper arm for tourniquet pain of the upper arm. If you had done that before you put the tourniquet on, you might reduce overall tourniquet pain. And lastly, the definitive therapy. If it's so bad, you can put them to sleep or you can deflate the cuff if their pain is intolerable. Tourniquet inflation deflation pathophysiology is the next keyword. What happens when you inflate a tourniquet on like the leg? Well, that's like what we used to do in trauma, put rotating tourniquets on patients to raise their vascular resistance and raise their volume in their body in someone who is trauma and bleeding out. When you put a tourniquet on someone's extremity for orthopedic surgery, their volume goes up, their vascular resistance goes up, therefore their blood pressure and CVP go up. The limb is not perfused, and so the temperature starts to drop in that non-perfused limb, and anaerobic metabolism occurs, producing acid and lactate. So you can imagine if that tourniquet's been up for a long time, what's going to happen when you deflate it? Well, those anaerobic metabolites are going to be released. Lactate goes up and hydrogen ion is released into the central circulation. Potassium goes up. There's that acute rise in end-tidal CO2 from metabolizing tissue that hasn't had a chance to send that blood back to the lung and remove the carbon dioxide from it. So there's a transient rise in end-tidal CO2. And that rise may be significant enough that it raises cerebral blood flow. And in someone with high ICP and fractures who you're trying to hyperventilate and control the CO2, when you release a tourniquet, you got to be aware that their end-tidal CO2 may rise, and you may want to increase their hyperventilation a bit at the time of tourniquet release. Their core body temperature can drop because that extremity hasn't been perfused for an extended period of time. The blood is cold, it comes back and mixes with the core blood, and the temperature drops. The volume and systemic vascular resistance decrease, and blood pressure and CVP decrease. So if a tourniquet's been on for a very, very long period of time, you may want to put them on 100% oxygen, give them some volume, raise their systemic vascular resistance a bit, make sure their bear hugger is on, hyperventilate them a bit more, and be aware that if they had electrocardiographic changes with deflation, they may be secondary to hyperkalemia. The next keyword is peripheral compartment syndrome. Acute compartment syndrome can occur when you have fascial structures that prevent adequate expansion of tissue volume, let's say a swollen muscle inside the fascia, and as the muscle inside either has blood in it or is edematous, interstitial fluid, starts to get big, it's limited in its expansion by the fascia, and so the pressure starts to build up. And the anterior leg is one of those compartments, as well as the forearm, where a compartment syndrome can set up, anterior leg being number one. And in the picture up at the top right is a anterior compartment measurement pressure being taken. When that anterior leg has compartment syndrome developing, often they will have pain out of proportion to the apparent injury. They're complaining of pain, and the 5 P's are characteristic. That is, there's a palpable pulse, and you think, well, if there's a pulse, they must be doing okay. Maybe it's not a compartment, but not true. When you lose pulses, that's a very late finding. But pallor, paralysis, paresthesia, and pain are part of the 5 P's of peripheral compartment syndrome. A compartment measurement, when you stick a needle into a compartment, Oftentimes, we say that if that compartment pressure is in the 20 to 30 millimeters of mercury range, they need a fasciotomy. Because if you leave a person with a high compartment pressures, such that it's so much greater than diastolic blood pressure, the muscle doesn't get perfused, it gets more and more ischemic, it swells more and more, and eventually the muscle dies, and myoglobinuria, rhabdomyolysis can occur. So pain, as that tissue pressure builds up, and if their diastolic pressure minus the pressure that you measure in the compartment, which is called the ACS delta pressure, is in this range of less than 20 to 30. So let's say their diastolic pressure was 50 and their compartment pressure was 30. That would leave a 50 minus 30 is only 20, and that person, you would say, needs a fasciotomy. And these compartment pressures can rise after surgery, after fractures, and we need to be aware of the 5 P's that would indicate a need for a fasciotomy. Rhabdomyolysis is skeletal muscle breakdown and is associated with an increase in creatine kinase in the blood, crush injuries to muscle, compartment syndrome, as we mentioned in the last slide or keyword, loss of blood supply to a muscle, strenuous exercise. Someone runs a marathon for the first time and they get brown urine and kidney failure. The brown urine is from breakdown of muscle, and shown in the picture on the far right what it actually looks like, and that's myoglobinuria, myoglobin present in the urine. There are some medications associated with rhabdomyolysis, like statins, some antipsychotics that can cause neuroleptic malignant syndrome, electrical injury where a shock damages the muscle, and prolonged immobilization. Someone who is down, laying on a floor, let's say with a drug overdose or a stroke, and is not found for 8 to 12 hours, can have rhabdomyolysis and myoglobinuria. How do we treat this? Well, the kidneys can be damaged by the myoglobin. IV fluids are needed. Sometimes mannitol and bicarbonate are used to try to improve renal urine output, and IV fluids to improve renal blood flow. And they may have hyperkalemia that requires treatment. Complications of rhabdomyolysis, renal failure, even requiring dialysis. The hyperkalemia because of the release of potassium from that dead muscle, and even to the point of cardiac dysrhythmias, and disseminated intravascular coagulation. Anesthesia-induced rhabdomyolysis, when triggering agents are used like succinylcholine to a patient with, for example, Duchenne's or Becker's muscular dystrophies, you can have rhabdomyolysis. And this is not a ranitidine receptor issue, such as in malignant hyperthermia, but the absence of dystrophin glycoprotein complex with instability and increased permeability of muscle. So it presents like MH, but it's not MH, and it's not treated with dantrolene. It is actually rhabdomyolysis, and you can get hyperkalemic arrest in a Duchenne's or Becker's muscular dystrophy treated with succinylcholine or administered succinylcholine. Methyl methacrylate bone cement is the next key word. And in the picture up at the top right shows a reaming of a femur. Bone cementing process associated with high intramedullary pressures can cause problems. And cement, fat, air, or bone can be embolized when those high pressures are developed inside the femur, for example. Methyl methacrylate is the bone cement that is occasionally used. When it's mixed up in the operating room, you can smell it. It undergoes an exothermic reaction, meaning it gets hot, and when it's reamed in place into the femur, sometimes profound hypotension and circulatory collapse occurs. Less than 5% of total hips during cementing this occurs, and the etiology isn't completely understood. Some explanations have centered around methyl methacrylate causing vasodilation, but don't really know the overall mechanism. It can embolize to the pulmonary artery. You can have lysis of red blood cells from the exothermic reaction, lysis of cells in the marrow from the exothermic reaction. So when bone cementing is going to occur, it's important to think, I want to make sure this patient's hydrated adequately before they ream the cement, and have them on higher levels of inspired oxygen usually, minimize the chance of hypotension with adequate fluids, and turn off nitrous oxide if you're using it, because there's a risk of air emboli during this process. The next keyword is perioperative blindness or ischemic optic neuropathy. In the case of orthopedic procedures, it's often spine surgery where a patient wakes up from a prolonged spine surgery with unilateral or bilateral blindness. It's painless, unlike, for example, a corneal abrasion, which would be very painful. Ischemic optic neuropathy of the anterior variant appears to be most common, but can be also of the posterior variant. And basically, it's ischemia of the optic nerve. If it's right near the back of the eye, and you can actually see changes in the optic disc with edema present, that would be anterior ischemia. If it's farther back on the nerve and you can't see any changes in the disc, that's probably posterior ischemic optic neuropathy. This risk of ION increases with prone procedures, spine, general anesthesia of long duration, large blood loss, male sex, and obesity. And recommendations are to not only use crystalloids but also colloids to maintain intravascular volume. There's no specific transfusion threshold at which we should give blood in an attempt to reduce the incidence of ION, but we should keep the head in a neutral position and avoid head down below the level of the heart. Rheumatoid arthritis and atlantoaxial subluxation is the last keyword. Anterior subluxation is quite common, up to 25% or so in patients with rheumatoid arthritis. And the picture at the far right is a X-ray of the cervical spine with neck flexion. And that is the way the cervical spine X-ray is done, with neck flexion. And when the distance from the anterior arch of the atlas to the odontoid is greater than 3 millimeters, there's a risk of cord injury during any time that you position the neck in a extension or flexed position. And flexion appears to be worse than extension. It moves that anterior subluxation, and the cervical spine, when it subluxes, can pinch off the cord. Rheumatoid arthritis also can have compromise of airways because their temporal mandibular joint can be stiff, their cricoarachnoid joints can be stiff, their neck can be stiff, and when you go to do a DL, it may be a difficult DL and difficult time seeing the glottic opening. So check your patients with rheumatoid arthritis for their ability to flex and extend. If it's really bad, they've had rheumatoid arthritis for a long time, they may need a cervical spine X-ray in the flex position to look for that anterior subluxation. Check their TMJ joints, and if they have hoarseness, they may have cricoarachnoid involvement. And all of these things are associated with rheumatoid arthritis and may make airway management more difficult. So we looked at the orthopedic keywords, including embolization of air and fat. We looked at tourniquet inflation and deflation and some of the bad things that build up in that extremity when a tourniquet is on for an extended period of time. Tourniquet pain and some of the things that we can do to try to prevent it. We looked at ischemic optic neuropathy as a cause of postoperative blindness, compartment syndrome, and the pressures that can build up in a closed compartment with fascia around a damaged muscle. And if that muscle dies and breaks down, rhabdomyolysis and myoglobinuria can occur. And we looked lastly at rheumatoid arthritis and the risk of atlantoaxial instability that can be present in many of those patients. And earlier we looked at methyl methacrylate, the bone cement, and how during reaming with bone cement, hypotension and even cardiac arrest can occur. And this ends our keyword review of the orthopedic topics from over a decade of American Board of Anesthesia in-training exam keywords. I hope you have a great day.